Welcome to The Pharmacist RN, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
Welcome back, everyone, for another exciting and informative episode of the Pharmacist RN podcast. I'm joined by Dr. John Papastergiou. And John, I just want to say, coming on after that music, I want to read my phone to you. I got a text message. I want to read it. It says, is a screenshot of the Pharmacists Are In on Spotify, which is one of the platforms you can listen to Pharmacists Are In. And it says, love the episodes, but even more so, loving the music. So with that, John, what are we going to talk about today on the Pharmacist?
Yeah, people love that intro, and I know we've talked about it before, but the guys, the group that did that, they're quite famous, still young. They were doing live to air here in Toronto last night. Z103, Manzone and Strong. They did like a 2-hour set, and nice. it was rocking. I'm thinking they got to do another intro or closing song for us, but that is a custom tune, and it's funny. I get asked that all the time. Or even Shamir asked us when he did the episode, whose intro was that? Where did you guys get that from? So it seems to be like, it feels like we're doing a lot on immunization, but it's that time of year, right? It's the busiest time of year in pharmacy for sure, and I think we try to schedule some segments on vaccination simply because that's what pharmacists are interested in right now. They're all, battling with, operational challenges. I'm not sure how that, I imagine it's just as bad, but we're still in a labor crunch here in Ontario. I'm sure BC is the same. It's hard to find pharmacists, very hard to find regulated tech. So our volume essentially doubles overnight once you start adding the vaccines on top of the prescription. So it's a really, really challenging environment for pharmacists over the next few months. And at the same time, they want to offer great care, make sure their scripts are getting out in a timely fashion. And most importantly, identifying those patients that are at highest risk and how do we, get them vaccinated, because we know these vaccines save lives, prevent hospitalizations, all this good stuff. We just got to get it into arms, and the data is clear. Patients want to come to us. They love the access. They love the convenience. And the physicians have really turned the corner on this as well. I mean, me and you do a lot of advisory boards with the docs. They want them to come to us. It's easier for them. They want these patients off their plate because they're busy enough dealing with other things. And I'm not sure if that's what you're seeing in BC, but I've seen that loud and clear here.
Oh, yeah. I mean, I think the focus of today's episode is on pneumococcal disease and vaccination. So one of the big sort of milestones and accomplishments that we've had here in BC is we now have a older adult PCV20 program, which we're using the polysaccharide vaccination, Pneumovax, which actually has been available since 1984. And I want to say that's the year my dad graduated from pharmacy school. So that vaccine predates even my existence on this planet. So it's great to see we've moved to conjugate vaccination, and we're going to talk about how conjugate vaccination against pneumococcal disease is particularly important. But the one big thing that we're really excited about here in BC, and we're doing a lot of pneumococcal conjugate vaccination, is pharmacists have access to the public program. So we're huge drivers of uptake, screening, identification. And I want to actually, maybe in another episode, talk about the COPD program we're running, where patients with COPD, these patients have chronic obstructive pulmonary disease, which is probably the worst comorbidity to have if you're afraid of lung conditions, viral assaults like influenza, COVID, RSV. Check out our previous episode on RSV, and secondary pneumococcal infection, is that almost more than 50% of these patients are over 65 and they have COPD and they haven't had any pneumococcal vaccination. So there's a lot of gaps, and as pharmacists, we're really showing that if you can screen, you can intervene. I know in Ontario, the public program is largely out of the physician's office,
See,
but
that's
how
the
great would it be
challenge.
to have pharmacists doing
That's
that?
what that's the challenge, and you hit the nail on the head there. So we've got these patients that are coming in. We're vaccinating them for COVID, flu, perfect candidates for maybe high risk or whatever for
Mhm.
pneumococcal vaccination, and you've got to send them away. It's not even about getting a script anymore. Like RSV, we could try to get the script and administer it. If it's funded, so you're sending them back. Now it's a huge inconvenience to the
Yeah.
patient. And when you talk about low-hanging fruit, like, I mean, it's great that it's publicly funded, obviously, now. I mean, that was a barrier we had to overcome. But the challenge now, again, is access. So you're telling a senior with risk factors or whatnot now that may have not been vaccinated, hey, go back to your family doctor, which is not always an easy thing in Ontario. We say
No.
it, but it's hard to get appointments. Wait times are long. Respiratory season's pretty narrow, so it's just I mean it's just one of those challenges. I don't feel it's necessary. We do have scope
Mhm.
coming. I mean, it's with the college now. And hopefully this is a barrier that by next season we can overcome and we have access to these publicly funded vaccines. But it's one of the big differences between here and BC and some of the other provinces. But I think with time we'll get there as well, because I think we'll be able to make almost an immediate impact, and we're
I
talking
agree.
about the pneumococcal vaccine here today, but we're getting asked. I know you're getting bombarded with these topics. I am. I'm giving a talk, I think Tuesday, for CPHA. It's a national one
That's right. I saw
on,
that on LinkedIn.
yeah,
Yeah.
you see that on operational kind of workflow. Everyone's talking about this right now because there's all these challenges, and I think it's great to be able to share our insight, but it's there's no cookie cutter approach. Everyone's pharmacy is different. They've got different staffing available, different volumes, different demographics. So it's easy for us to sit here and say, hey, plug in an extra RSV vaccine or try to get these guys vaccinated for pneumococcal vaccine. But what the pushback is from pharmacists is, okay, no problem. How do I do it? Right. So
Yeah.
that's
Yeah.
that's the challenge, and I think as a profession, we're trying to kind of overcome that now.
Definitely. And I think it's great to hear, some of the advocacy. And I think one of the main motivations is in doing well with this in BC is to showcase that we can actually reach, and we've done work on this before, John, the 80% challenge, right? So the Public Health Agency of Canada set a target for 2025. So here we are at 80% of those over 65 and those 18 and over who are high risk have at least one dose of a pneumococcal vaccination. And as of 2019, 2020, we were not even close to getting there. So I think one of the key advocacy things is, hey, listen, if we're reaching target, then why do we need other vaccinators? But we're not anywhere
Yeah.
close. And these patients are seeing pharmacists like yourselves and your colleagues who could easily not just have the conversation, but also, close the loop and administer the vaccine, especially if it's publicly funded. I think it's pretty straightforward for sure.
Yeah, and one of the challenges I get with pneumococcal disease in particular from patients, and especially when you're making these recommendations with the guidance changing pretty regularly, as well as, listen, John, you told me about, I had, I got Pneumovax. Then you were talking to me about Prevnar 13 or whatever. And now you're telling me about another vaccine. Like, what's going on here? So I think that's one of the barriers that pharmacists, or the challenges that we're faced with. What do you say to the pharmacist that says, hey, man, it's like not an easy sell anymore, right? To make this, people are vaccine hesitant. We've been talking about
Mhm.
vaccines. There's some fatigue out there. How do you address that one in your practice?
Well, especially if it's a pharmacist colleague who's having that fatigue of the conversation, and absolutely, we've seen the evolution of pneumococcal vaccination from polysaccharide to conjugate to expanded valency conjugate. So polysaccharide, as I mentioned, Pneumovax, 23 serotypes, but as a polysaccharide, we don't have that sort of conjugation with a protein, and therefore no T cell mobilization and no robust immune response. And that's why we had PCV13, which was a conjugate, and then now PCV20 and also PCV21 as well, Capvaxive, that have expanded that. So the first thing I asked my colleagues are, what kind of phone do you have? And this is actually something and you know where I'm going from this, I can see you nodding, is from my colleague, Dr. George Zanel, a good friend of ours, who's such a good advocate for pneumococcal disease prevention and AMR, is, listen, we have no issues getting the latest iPhone and upgrading our sort of, mobile experience. This is the same thing for the protection of your lungs and your blood and your cerebral spinal fluid against a terrible bacterial pathogen. So it's upgrading protection, it's evolving. What we look at is, if we look at epidemiology, we do see serotype replacement. So when we vaccinate against one, then the ones we aren't vaccinated against tend to pop up. So it's an ongoing sort of battle between surveillance and vaccine programs, and we have to stick with the times, because regardless of community cases, if pneumococcal pneumonia becomes invasive, that is a serious hospitalization, potential ICU. If we look at the data, actually, patients who are hospitalized with community-acquired pneumonia go on to, significant number of them stay in hospital. Some of them actually, if they're followed, and I'll post this study in the show notes because this is a key one, they're followed for up to 10 years, there's an increased association if they've been hospitalized for pneumococcal disease and risk of cardiovascular disease. So clearly it's changed their inflammatory processes. So it's a very important disease to prevent. When we talked about in our previous episode with COVID, flu, and RSV, especially with RSV, it's those secondary infections that really do people in, right? So it's very important that we prevent the viral illness, but also that secondary bacteria, which a lot of times is Streptococcus pneumo. It hangs out in the nose and the throat. So making sure the protection is as most up-to-date as possible. We're up-to-date with our phones, our subscriptions. Why would we not do the same for our lung health?
No, that's a great analogy. And I like the whack-a-mole analogy as well. You suppress one serotype, another one will pop up. And that's what, the broader spectrum protection is so important because of that. And I think all we could do, as pharmacists, is make that strong recommendation based on what the guidance says. And, you won't get everyone, but you'll get some, and you'll get many, hopefully. And that's, I think, one of our most important roles here, beyond simply administering, is that health promotion aspect as well. So, what's changed? You want to give us a high-level summary with respect to pneumococcal disease? Because, I know we've got potentially a new vaccine coming as well. What's the difference? What do you know? It's it's obviously an evolving science.
It absolutely is, and I'll give you the quick update. So I think the best resource we can look at for Canada is the updated pneumococcal vaccination recommendations for older adults that was published in November of 2024, which basically states that one, conjugate vaccination, especially multivalent conjugate vaccinations, so that's PCV20, also known as Prevnar 20, and Capvaxive PCV21, are really the gold standard of vaccination for patients over 65, even if they're healthy with no comorbidities, for patients 50 to 64 if they have a chronic medical condition, and patients 18 and over if they have immunocompromising condition or they're immunosuppressed from certain medications. So when we look at those cohorts, this is the gold standard. And the one thing we see in that statement is, regardless of their pneumococcal vaccination history, whether they've gotten Prevnar 13, Pneumovax 23, is if it's been at least a year, they should get either PCV20 or PCV21. And actually certain populations, a very specific population, hematopoietic stem cell transplant, that was a mouthful, but I said it. That's a significant immunosuppressed population, oncology patient population, should actually get both PCV20 and PCV21. But that's the only population that would get both. The reason why I'm saying this is because it was very clear by our national guidelines that patients should upgrade their protection. So I'm not just saying this about phones, it's written in the guidelines, and we'll post that in the show notes. The one challenge, though, is from a public program perspective, and this is in Ontario and in BC, is they put some restrictions on who can get publicly funded PCV20, because PCV20 was chosen as the candidate, as the public program. Interestingly enough, and we won't get into the weeds of this, but I'm sure there'll be questions, is how do you choose between PCV20 and PCV21? Well, that comes down to surveillance, right? Is what is the most common serotype? And what we see is Canada, and we talk to each other all the time, and our scope is different. It's like we live in different countries, right? So in each province, there's different distribution of serotypes that cause disease in kids as well as in adults. So depending on which product, PCV20 or PCV21, the goal of a public program is to capture the most predominant serotypes that are captured by those contained in the vaccine. So if you look at the BC CDC manual, which I posted, I think page 18 or 20, there's a really good table that they have that shows that PCV20 captures, I believe it's serotype 15, that was not in PCV21. So it's very, testing is so important, John. We talk about it all the time, surveillance, how are we using the best product at the best time? But at this time, both of our provinces are doing PCV20. They do have a caveat for now that they want to focus on, for most healthy patients who are over 65, they are pneumococcal naive. So they've never had a pneumococcal vaccine. So if they've had pneumovax before, then public, in BC at least, they won't fund it publicly. But the patient can still purchase that out of pocket. So I still think the payment conversation, we've been having this for so long with pneumococcal conjugate, we should still be able to have it because NASI supports that.
Yeah, that's important. I think that's, one of the things, community pharmacists, we don't get a lot of visibility to what's circulating, what the most common underlying pathogen is and whatnot. So I think that's why we rely on, segments like this and NASI to help kind of help guide us, because pharmacists are really practical individuals. They got to be jacks of all trade. There's a ton of information. We're doing minor ailments now. We're prescribing for chronic disease. You're vaccinating, and you get bombarded with questions, and it's very, very, very difficult for pharmacists, the run-of-the-mill community pharmacists, to be up to date on everything, right? So it's I think that's a really good summary. So let me, common patient. We've got right now, I'll see it every day. You got a patient maybe with diabetes, hypertension, comes in, is getting a flu shot, doesn't want, COVID, feels like they've had too many of them. And, how do you approach that patient right now? What's your strategy? Because I like these take-home tips, right? Because a very common patient, right?
Oh, definitely. I think the thing is we've got to be like pretty blunt about it and just kind of talk about how well we know our patients, and we know that they're at risk for these preventable illnesses. So I think the one thing I like to highlight is how simple as a risk mitigation measurement this is. So, we look at diabetes management. I think the recommendation is like 150 minutes of physical activity a week, right? Canada's food guide. I can't even remember the last time I looked at Canada's food guide. So we have lifelong interventions for these patients. They take their medications every day, which are very challenging to follow. Testing, taking medications, following diet, exercise. How simple is it just to get a single vaccination, in this case pneumococcal? And even if they've said they've had too many COVID shots, I mean, one every season, they get their flu shot every season. So even if you get one every year, that's a 365-day intervention. So putting it into that perspective, to make themselves healthier, if they're motivated to improve their health and well-being, then this will resonate with your patient.
That's so important, I think. And I think, what we struggle with in pharmacy too is that rabbit hole, right? So you're busy, you've got a lineup, you're waiting People are waiting for their scripts, they're waiting to talk to you, and then there's the appointment-based stuff now as well, and we're doing much more of that, right? And in my practice, I don't turn anyone away. You could have an appointment if you walk in, you're getting vaccinated. We just got to kind of cue you in somewhere. But I think what many pharmacists fear is, I got this patient now. I know everyone's waiting. I'm going to make this recommendation, and now I'm going to get bombarded with like 60 questions about it. So this intervention now that I thought was going to take me 2 or 3 minutes is going to take me 20, and the work behind you doesn't disappear, right? So that's why that preparing, the scheduling, the making sure you're equipped at the pharmacy, it's easier said than done. I get that as well. Will allow you to do that, because that, I think, is still the lost opportunity. I still hear anyways of pharmacies that, during flu season, they'll schedule no more than 5 vaccines an hour, just because they, the workload that comes with it and everything else you're doing, they just can't manage it. But I'll tell you, I'll do, in excess of 7,000 vaccines this season, at one of my stores. So it's possible to get it done, but you got to equip the team to do it, right? And if we're talking about incremental vaccination like RSV, like pneumococcal diseases, are you taking the time pre-season to really plan for it, and plan for it now? Because if you wait, you've missed it. You know what I mean? It's a blink. Like, we'll run out of high-dose flu in 2.5 weeks. We'll be gone, right? And then, we're still vaccinated for flu, but that mad rush happens pretty quickly, right? So it's, going back to your team, having this conversation and preparing for it. And if you're able to do it, you can really build a business around it. And I think the respiratory season, now that builds onto like travel, and then you become known as a destination. So how do you take all this stuff? And you've done a better job than anyone at building a business out of this and becoming a destination. But I think, I started with saying the public wants it. If you build it, they'll come, right? It's just a matter of how do you do that. And I think, you've done that better than most. But I know it's taken you some time to get there. It doesn't happen overnight.
No, it doesn't. And I think the one thing we should, if you want to be a destination for immunization pharmacy, and this is across the country, is you've got to get into a cadence of a year-round immunization program. So it's not just COVID and flu. And we often hear anecdotally pharmacists like, I forget how to give an IM because it's been an entire year since the last season. So anytime you find yourself in that situation, I think you're a little far from being destination immunization. But pneumococcal vaccination can be done year-round, right? So we talk about co-administration. Yes, it is absolutely safe to administer pneumococcal vaccination with RSV, shingles, flu, COVID. It's not the issue. I think you hit the nail on the head. Is are we being realistic? So in our previous episode, we talked about how mentioning RSV in the same breath of COVID and flu, because when we look at our dashboards, that's what's tracked. Pneumococcal ties into every single one of those. All of those potentially can infect a patient, cause a lot of issues in the lungs, and then strep pneumo comes down from the nose, throat, and potentially can go everywhere. So making them aware of, are they up to date on their immunizations, focusing on respiratory when it's respiratory season, but having a cadence for them to come back, because these are our pharmacy patients, right? Especially the ones who ask for flu shots in July, right? Who are regular patients. And we always say, we want to make sure we provide flu shots for our regular patients, because if you're doing 7,000, you're getting walk-ins, etc. So I think that conversation does not have to happen in that particular visit, but it's something we should be thinking about, because that's the full picture. So for any pharmacists listening to both of these episodes, that would connect the full picture in a year-round immunization program, is looking at your immediate respiratory needs, but also looking at that subsequent visit to mention pneumococcal vaccination to the patient, because it ties into it.
Yeah, and for anyone that's worried about giving more than one vaccine or more than 2 vaccines at once, I always love your story. What's the most you've ever given at one shot?
I know you keep asking me this, and in travel medicine, we often have to give quite a few immunizations because of limited time and multiple antigens. So I'd probably say, my record was about 8 immunizations. So 3 IMs in each deltoid and 2 subcutaneous immunizations.
Yes. So I think the point is it's safe. Experts in the field are doing it. Don't be hesitant. It saves time. You get them done at once. And patients actually appreciate it, if
They
they're,
do, yeah. And I would say, like, don't be hesitant if the patient asks, right? If
yeah,
they say, yeah, I'm open to getting all these done because I'm here and I value my time. Don't kind of say, oh, my limit is 2. That's not acceptable.
yeah,
Now, if the patient really insists that they'll come back next week and you know that they'll come back next week, that's totally fine. But don't limit co-administration because you don't feel comfortable. You have to feel comfortable with it. That's what makes the patient comfortable, and that's what makes it happen.
yeah. No, and you made a point about immunization being year round if you want to really offer a true program. The other thing I've seen as a challenge for pharmacies is a big variation with respect to what they offer, like during the day and the evenings, right? So they may have their A team on during the day, the regular pharmacist, they might be using relief in the evenings or whatnot. And they almost have a 2-tiered service offering. Whereas if you go into this pharmacy during the day, you get pretty much any service. You go in at night and the pharmacist will say, well, just go back in the morning, and they'll do that. You've lost that patient in many cases if you do that. They may not come back and you've missed an opportunity. So are you offering the same quality of service, at all times when you're open? And I think that's a huge opportunity for community pharmacists as well. I'm cognizant of the time again. And I just wanted to end. What's that therapeutic pearl for this segment around pneumococcal disease? And, what do you want our listeners to take home today?
Well, I think it's just the big thing is understanding the burden of pneumococcal disease. A lot of patients it will resonate with them and they'll say, like, oh yeah, pneumonia shot, but many of these viral pathogens and bacterial pathogens can cause pneumonia, but it's pneumococcal disease caused by a specific bacteria that lives in the nose and throat and can potentially be invasive. So understand the burden of disease, very quickly explain to your patient the difference between polysaccharide conjugate and expanded valency, just kind of saying better immune response covers more bacteria, serotypes, right? So that's how you upgrade the protection. And from a workflow perspective, it's a year-round project, right? Don't pressure yourself and jam pack everything in flu and COVID season because it's sort of the jack of all trades, master of none. Have that pneumococcal conversation as an ongoing opportunity to discuss with your patients, because invasive pneumococcal disease, even though we do see spikes in seasonality with these respiratory ones, it's year-round. So I think that's the key thing, is this is a key vaccine to get to a year-round immunization strategy.
That's great advice. With that, I think we're going to wrap it up for today. We do have some big surprises, I think, over the next few segments for our listeners. We'll keep an eye out for some of the ads that go out. I think we got some exciting things for the pharmacists RN, but it's always great talking to you, and I'll see you soon.
Same to you, John. Take care.